Well, I would like to welcome all of you and thank you very much for coming to the very first talk of our Engineering Speaker Series this year. It's a pleasure to have you here, and I have the pleasure of having Dr. Chen to introduce our first speaker today.
Okay, thank you, Khosrow. So we're very fortunate to have Dr. Eva Lee here today. She was pretty hard to wrangle. We got her for one day, and that was it. She's traveling around the world most of the time when I'm trying to find her. You got her some of affiliations here. She's a professor of industrial and systems engineering at the Georgia Institute of Technology. She's also director of the Center for Operations Research in Medicine and Healthcare, and many others. She's been advisor to the White House. Her center was funded by the National Science Foundation and the Whitaker Foundation. And if you Google her, you can find a whole lot of information about her. So I'm going to tell you something else. I've known her for 17 years. We were together at Georgia Tech, colleagues together at Georgia Tech, and we spent a lot of time together. I would say that I have the greatest admiration for her, not because of her long list of accomplishments, which she definitely has, but because of her integrity. She has great integrity. There's great integrity in her work. I can tell you that she chose her research not because she thought it would get her a lot of funding or because it would improve her reputation. She chose it because she saw the importance, she saw the potential, she saw the need, and she wanted to make a difference. And you see her today, now 17 years later, she really has made a difference in the world. And I see her as being a true, genuine pioneer and independent thinker, and she's very rare. So we are very fortunate to have her, and I'd like you to please welcome her today.
Well, thank you for inviting me to here, and thank you, Tori, for such a nice introduction. I guess she wanted me to look at her speech this morning, and I told her to surprise me. And I guess she did surprise me. But I think most of you, I think there are lots of students and lots of faculty here. I think one of the greatest part of being a faculty is exactly we can chase after our dream and a passion that we do. And I know there's always hurdles, is that somebody's going to tell you, don't do it because you will not succeed. I guess I am very good in not listening to those advice. So yes, being very independent because I figure somebody failed and somebody's going to succeed, and it might be me. So I guess that's how I stumble in this area. And I think it is a lot of fun, but it is really a lot of challenges, but the reward is really what counts, and you have to be really patient, and I think there's no quick fix, right? We always know no food is good if it's too fast. And so just like everything else, it takes time to get the best type of research. So I think that's the part that I'm sure every one of you share with the same idea. So what do I do in healthcare? There's a lot of applications that I do. And so my training is in mathematics and computer science, and basically I'm trying to advance the mathematics and computational area so that we can actually really solve some real problems. So the first problem that I deal with in healthcare is on prostate cancer. That was at Columbia University. I was the first female faculty being hired by IEOR. And I was really lucky because the doctors took me in and taught me lots of things, and because they knew that I know nothing about healthcare. So I was really lucky. And so basically we look at really a lot of applications, not just in healthcare management side, but looking at early disease diagnosis, looking at optimal treatment, looking at global health, how do you handle emergency medicine? So it's really fascinating. So I'm going to share with you a few examples today. So we do preventive and predictive care. A lot of the projects relate to how can you diagnose things early? What does that mean early? Not just when there's cancer cells grow, but how can you diagnose when the cancer are not there yet? And they are very important because one of the earliest form of tumor that I look at is brain tumor. And that is the second most common form of cancer among children. But the moment it's diagnosed, no matter how tiny it is, many forms of brain tumor is incurable. So we lost a big chunk of the time really to be able to recover. So it really motivates me to work very hard to find an answer for that. So we do some of the drug design, working on medical countermeasures. How do you design drugs fast enough so that patients can benefit from it. And if there is a biological event, how can we actually get those drugs out fast to the individuals? And that's personalized treatment. So we talk about a lot of evidence-based treatment. So it's interesting, one of the things that there is no evidence, if we cannot really look at globally all the patient treatment and figure out exactly what are the patterns among that. So now this is the time, because there's lots of data. Of course, my students will tell you there's lots of data and they are not pretty data. No data is pretty, because if they are pretty, then maybe they don't need us, right? So that's the part of it. So we use a lot of those data to design treatment plans so that it is specifically for individuals. And that's the really making sure the cost is really reflective to really how effective it is. Now, one of the things, of course, we are in the United States, and for the longest time, even now, is that we were told that it does not matter how much it takes to get like certain answers to healthcare. But it does matters. If we don't have the money, we cannot afford to actually make the treatment. So cost effectiveness is really quite important. And you also notice is that cost is never on our equation when it comes to designing plans or looking at any of these problems. But cost is a byproduct. And let's say it is that when you really improve your quality, you also reduce your cost. So that is just come, and I like it, it's a free perks, right? Why not? Since I don't put it in the objective function. So the back end, again, this is like, some of you already may have seen it this afternoon, is that the finance and all the supply chain logistics system is really quite impressive in the United States. So now let's not think so hard about just United States, because I was invited to go to China, so I have only been there twice. And they want me to look at the hospitals. That hospital I visited has 4,000 beds. There's not a single hospital in the United States that have 4,000 beds. And so they ask, how do we do bed assignment, inventory? I said, we got robots, okay? Okay, we got robots in some hospitals. Not every hospital, but Grady has robots. So of course I can say, but okay, there are no robots in China, in a hospital. How do they do bed assignment for these 4,000 hospitals? What is your guess? They do it by hand. Now, can you imagine somebody's going to count the bed in the front part of the building, and somebody's going to count the end part of the building? They would never be able to talk to each other anyway, right? It is so big, the hospital. So you can tell how much inefficiency they have, and they want our help, because China, believe it or not, they don't have enough people. So, and I thought they have lots of people, but they don't have enough people to do just that. So for them, their healthcare system needs a lot of improvement, exactly like us. We're just all facing the same problem. So now there's also this whole idea of big data. So I think we need to understand, and I want to make sure that everybody knows it. There is a problem when there's too much data, because you have to be able to extract from a lot of data something that is important. There's also a lot of problem when you don't have enough data. How do you construct a full picture of something that is missing, right? Like, for example, in drug design, it is impossible to really figure out what is the optimal dose for a certain type of drugs. The way it is designed is that you do multiple experiments and you say, this is the optimal. But you all know, right? All of you are engineers. You know that is not optimal. It is just that based on the experiment, we know like X number of experiments, we choose the one that seemed to be the best. But there's no, it's not optimal. So how do you construct the best response compared to other type of drugs? And it is really difficult. And in this particular picture, what I want to show you is that we don't just have hospital data. We have genomics data, we have risk factor, we have family history, we have everything that is at our fingertips, assuming you can get those data. How do you handle that? How do you handle all this data so that it can really help you to make a difference? So some of the healthcare issue remains exactly the same: quality, cost, technology, accessibility, service, and finance. So what you do notice is that I think a year ago, yes, 2013, I was chairing a panel. So I happened to chair a lot of healthcare panels with debate that people really got really passionate about. So that was an interesting one. So this guy, one of the leaders, said, Eva, we've talked about all these things 50 years ago. So that's what he said. I said, what is all the differences? So he asked me, okay, as a panelist, as a panel chair, then I have to, I said, because we are not there 50 years ago. And I am not kidding.
right? Because you can say you faced the same problem 50 years ago, and we are facing the same problem, but the data is not exactly the same. All the challenges may remain exactly the same, right? But the demand has moved, data has moved, technology has moved, and all our challenges may have been overcome, 50 years ago or 40 years ago. Now it comes all back to us because you got another set of challenges. So these are not new issues. But on the other hand, what we are facing as this generation, it may be new to us or maybe it's not. But nonetheless, they are here to stay, unfortunately. So I lead two centers. So one of the center, OR in medicine and healthcare, we deal with more on the medicine side, translational research, clinical and translational research, preventive and predictive, diagnosis, treatment design, and treatment delivery, outcome prediction, and public health. So this part, as you notice, is everything that is related to the individuals and also population. So these are some of the projects, and I won't go through that in detail, just to give you an idea, is that outcome prediction is really quite fascinating, is that we are the first group working with Emory University and Harvard to really come up with the gene signatures in which we can actually decide if you actually respond well to a vaccine or not. So that means in the future, so this is quite interesting because I thought about that 20 years ago and the doctor thought I was just totally crazy. And in the future, you can line up and get your little DNA test, and that we can tell you right there in real time whether you should take the vaccine or not. Why is this so important? Why is this so important? Because it's individualized in a sense that if there's adverse effect, you know you won't be the victim, right? That's most important. How many of you have taken flu shots? Okay. You have a more population here then. So usually among the citizens as well as the really well-educated, it's almost equally the same. It's only 1/3 of citizens will do the flu shots. And partly because they think that they will be this really rare percentage of people that will have really, 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 really serious adverse effect. But unfortunately, that is sufficient to scare them away, right? I mean, so this is really important. So in the future, you won't have to be afraid of that because we basically have to look at what's going on. And this is very important. So we have done it for yellow fever, for flu, and we just finished the malaria, which is really important because the malaria vaccine only works for 1/4 of the population. So what does that mean? Like, if you don't really be benefiting, right? If you are not really benefiting from this drug, you better not take it because you are going to have adverse effect. So we are able to identify these individuals who should benefit from it. And we have been working with many different type of doctors and biologists. So there's lots of very interesting problem here. Then on the back end is the delivery side, which look at the quality, efficiency, data management. It's always important. And data management is important for every single department. So we like to think computer science owns this, or the systems, or mathematics. It does not. It doesn't work like this these days. It's that you really have to work with everybody because the data is everywhere of different form, and not a single individual will be able to really understand all this data. So you do need to work with many different type of people. The last two is really important. Change management and organization transformation. So how do you put your ideas forward so that your clients or whoever that you work with will listen to you? So this is really quite important. And I think it is always difficult. So I remember as a mathematician, and I remember the first time I was presenting at a medical conference. I actually was in the panel, and I was the only one that is not Ph.D. And I loved the reporter saying, "You are the only mathematician that can talk to anybody else besides, right?" And that actually made any sense. I said, okay, is it a compliment? Or then I said, how many mathematicians have you talked to, right? So I think it is difficult, is that the idea that scientists or engineers actually are better because you are supposed to solve their problem, right? So they should listen to you. Mathematicians are a little bit different. We solve our problem. And then if somebody wants to hear that, fine, they are okay to listen. So it is a little different. But I think as an engineer, you should be really good in terms of being able to convince them. But nothing comes easy. It is not so easy to tell them to change because you can tell yourself to change. And how hard is it for you to change? It's impossible sometimes, right? It's not possible. So I think change management is really important for an organization to be able to really move forward and be innovative. and not fall behind. You will have to be able to really be very critical. That means you know what you're good at, but you have to be almost so critical. Further, much more critical is knowing what you're not good at. And I think sometimes it's really difficult because they may know it, but the CEO is not going to talk to you and say, we are really bad in this. But sometimes they do, right? They grab you and say, oh, look, this is really bad, can you fix it? And fine. But usually their idea of fixing it is very different than your idea also. So I think all these is kind of, I think I learned a lot by working with a lot of different people. And I always find it interesting because there's so much for me to learn before I can really tell them what I think. And one of the things that I don't do, as I know it's really common, is I do not try to talk in the way that there is a common language between the two of us. The only common language we have is English. If they don't speak English, yes, we're going to have some problem, and we will translate. But I do not mind if their terms are different than mine. In fact, I would take that as an advantage. Like, for example, the first time when a doctor said, he was really quite excited. He said, oh, it's good that you know OR. Well, I said, of course I know OR. That's my field, right? This is my area. That's my area. And he looked at me and I said, oh, I didn't know that. And they said, and then he took me to the OR, right? The operating room, and said, that's the OR. I said, okay, now we got a common language here. And so the idea that you are afraid not being able to talk to each other actually doesn't really exist. You just have to talk to each other and understand the terms. But it is very important to use the exact terms. That is what I really insisted on. For example, I will not be willing to create a term just so that I can talk to my own colleague that is different than what the doctor's. If the doctor is using this term, that's all that I'm going to use, and no difference whatsoever. And I think that's really important. So together with the two centers, so this is some of the work that I do, is a lot of work, and in terms of the type of projects that we do, and it's a lot of fun also. And of course, I think I'm always optimistic, so I don't think I take a failure as something bad, because I think it's I always think of it that it's a good learning, so that I will not commit the same mistakes again. So today I'm going to cover 3 areas, and as you notice is that I don't know the background of the audience, and I know that this is a little bit general, so I try not to get into too much detail, but I will, for those of you that love mathematics and love the challenges, I do have some formulas here, but I won't test everybody about that afterwards. So I will talk about 3 areas: the predictive modeling, personalized evidence-based treatment, and the operations advances. So so I will start with the first one. So this one relates to predicting risk factors. Like the first one here, that's on the DNA epigenetics. So we look at the changes in the DNA with respect to cancer patients. And I have been really lucky because I have worked with some of the top biologists and clinical researchers, and they really taught me a lot. So we also look at the green picture here is the fluorescent imaging of different type of corpuscles in the body. So when patients actually start having disease, they will have little pockets of corpuscles, and those are the blood vessels that are grown to supply blood to the bad cells and everything. So how do you identify those things related to many different? Then there's the Alzheimer's disease that we look at, and also the metabolomics. So metabolomics is very interesting, and although I have absolutely no talent whatsoever in sports, I don't know anything about sports, but I actually work with the sports, the athletes, and very interesting is that they actually have regular checkup on all their vitals and everything. But the first sign of their illness, when they have heart disease, what will you know? When will you know, usually? When they have practice or they are on the court, they dropped and they usually died, right? And their doctors would tell them there is no symptom of the illness because they really do have very rigorous clinical checkup all the time. So what we do for metabolomics basically is checking all the metabolites and every functioning in the body, figuring out what are the deviations and stuff from the normal status. So this works out to be quite well. So these are all healthy individuals looking at what exactly is changing and how do you predict the status. So this one is the outcome prediction. This is the vaccine prediction that I mentioned. That's for the flu vaccine that we predict, and basically we finished 5 trials of patients, and we were able to predict across different years how individuals react to the flu vaccine. Then this is for characteristics of hospitals. These are like patients, how do you provide demand and how do patients actually come back? So this one consists of hundreds of hospitals, and we predict under what conditions that individuals would go to which hospitals for what service. It's a lot of fun. It's like, I cannot say I know all the detail of the medical stuff, but I learned enough that I need to understand exactly what do you want. And a lot of times it's not so easy for them to articulate their objectives. In fact, I think my idea is that they would tell me whatever they want, and I will do whatever that I think that is what they want, right? So, and then we will converge very nicely. And I will give you an example why. Because it is hard for someone to imagine what you can do for them, especially because you are quite different from them, right? On the other hand, it is very important for you to learn their problem and to learn it so well so that you can actually expect, if I solve this problem, what is the next problem that they have? And I think that is really quite true. And so I think they trained me well that they always have more problems than they told me. So this one is predicting the readmission of patients. So you can see that it is really broad, right? From really diagnosis to predicting outcome, evidence-based, to predicting the characteristics of the company and what type of services they provide, and also the characteristics of individuals. It is not just for healthcare, clearly. You see that it is even just for any service sector. So the optimization model, this is for some of you that are into mathematics and computational stuff. So we have G groups of individuals, and you can think of N entities are N patients, the entities as patients, and that those the M attributes are like laboratory tests and every type of things that you can collect for individuals. And then we have the mathematical models. So this is to show you from the academic point of view, it is really true that you can advance the area. There's a lot of mathematics to it. So if you want to ask me, how long does it take me to actually come up with the solutions? When I first started at Columbia, that's when I started the medical area. So I wanted to do Alzheimer's. I don't know why. I thought it is important. That was 17 years ago. And a doctor said, Eva, you cannot do it because you're way ahead of what they can do. At that time, 17 years ago, the only way you know someone has Alzheimer's is when they died and you do autopsy. So they look at me like, okay, you wait. So of course I said, okay, I can wait. And I come up with the mathematical model. And this is a good model because it is so hard that no one can solve it. So we come up with a model that we cannot solve and say, this is great. And so the doctor said, good, you spend some time trying to solve it first and figure out the issues. So this is the optimization model that turned out to be the hardest. It's NP hard and it's multi-group. And the idea is really to be able to understand how do you select features out of these millions of features that could allow you to predict, right? So that's really the machine learning features. Then there's a lot of properties here. I won't go into detail. Basically, what it tells you is that mathematically, there are a lot of things that is really interesting. So I think that is what we would like to know. Is that do we already have the technology that we can solve every single problem in the hospital? The answer is absolutely not. We do not have all the technologies because the data is difficult to analyze, and the model is equally hard to really solve these problems. So I spent 3 years on this problem, and very interesting. Then I was recruited to Georgia Tech and Emory. I was the first faculty that is being hired between the Georgia Tech and Emory Medical School. And so, of course, then I, again, think about what type of clinical data that I want. So I started doing the prostate cancer at Columbia University, and I will mention that in the second project. But then at that time, then the cancer biologists came to me and said they want to do the epigenetics, which is really one of the hottest topics. And of course, we don't know anything about epigenetics, and so the scientists taught us a lot of the things. And then we were the first group using this model, be able to classify the breast cancer patient, precisely the patient that are more susceptible to have breast cancer versus the patient that are not. And using those data, we were able to predict with 85% correct the subsequent patients, the new patients. So that's really quite exciting. What happened is that after the paper was published in PNAS, Duke reproduced the whole result using our pattern on the mice model. And so that's the validation that is not on human, because our study is on human and they do it on the mice. It is really quite fascinating. And then 5 years later, we tested using the signatures that we did and predict the lung cancer, like the susceptibility. So you can see it is quite beautiful, right? You go from breast cancer, and it actually, the rule from there could predict lung cancer susceptibility. So this is the beauty, is that from my point of view, because we were not trained by disease, so I really would not know the difference anyway myself. But on the other hand, we were able to really use the results and be able to predict many different things. And that's one of the successful projects. And it's really quite exciting. I think the interesting part, the cancer biologists, people ask, where do you get those patterns? I say it pops out from the computer, of course, right? I mean, from our computer. And what they really want is, how do you know these are the key patterns? I said, of course, I have no idea what the biological meaning is, because you are the expert, so you're going to tell me what happened. So it turns out 2 of the 7 sequences that we identified were ancient cancer viral gene, where people suspected that it relates to cancer, but they don't know what it is related to it and where. We identify exactly the chromosome, the length of the sequence, exactly where it is in the body, like in terms of the chromosome. So this is quite interesting. And of course, they like to know how we get that. I said, I have no idea about cancer biology stuff, but it really pops out from the computer, and so they're pretty happy about that, right? So it's a kind of a nice collaboration, because it is different than, if I look at my solution, I can tell you it is the correct one. I cannot, because I am not expert in that. I need someone to validate that. So the second project is on the cancer one that I'm going to talk a little bit like the example. So this is on individualized design. Basically, being able to use all the data that is available and really come up with personalized treatment. At the moment, we are not doing that. A lot of the treatment do not use biological information. They do not really use the individual risk factors, because it is complicated to design those. And this one, I'm going to share with you, some of these already have been standardized in the United States. And so I'm pretty happy. I cannot complain about that, because I did see a lot of the fruits coming out from the research. So I will share with you some of these problems. So this is the prostate cancer. This is my very first project. And so to give you an idea how it started, because everybody likes to know, so I was the only female faculty in the IEOR department, and I was invited to many different seminars, because it is at Columbia, they are pretty interested in really making sure everybody has collaborative ability or meet some people. So I went to these cancer conference or seminars, and there was the Dr. Zeta was presenting prostate cancer challenges and everything, very complicated. And out of the blue, so he said, here's the challenge that we don't know what to do. And so he put this problem on the slides, and like, you know, the old-fashioned slide. And then he said, I would really love someone to solve it. And among the audience, I was the only one that is from the engineering school. And there was a very famous statistician from AT&T. He was there, the audience. He stood up and he said, I think this problem could be solved using mixed integer program. Okay. Also, Dr. Zeta said, what is mixed integer program? And the expert in statistics, he said, I don't know. I love this guy. I think he was really, and I thought to myself, this is crazy, because I'm the only one that is doing mixed integer program. And I was the new faculty. I'm sure he has not even seen me, because he was in the front. But I thought, this is great. You know, somebody actually advertised, right, for me. So afterwards, I sent an email to Dr. Zader and said, I'd like to see him and just talk to him about his project. Well, when I saw him, he said he has no interest to talk about that project, because that was what he has in mind that day. Today, he has other projects. So he said, now I'm going to take you down to the hospital, and you're going to see the treatment, and you're going to tell me what you can do. I said, okay. So I went right into the OR, to the prostate cancer treatment. I was really shocked what I saw. It's, first of all, the patient is surrounded by all the computers and imaging, everything that you could imagine. And now that was not the first time I saw a patient lying there, and you know, with all the blood and stuff. But on the, it is quite shocking. And so then he said, after the operations, which lasted for like 4 hours, and he asked me, what was your impression? I said, my gosh, you know, it is not mathematics. In fact, mathematics is so easy compared to the treatment, because everything seemed to be so not quite perfect, right? Because think in this way, You come in 1 month ago, and we take image of you. We spend 1 whole month designing a treatment plan that is perfect for you. We have every single, like at Memorial Sloan, that is the oldest cancer institute in the world, so they have everything that you want, right? Perfect individuals. All right, on the day of the treatment, what happened? On the day of the treatment, what happened? The tumor, yes, it is 30 days have passed, right? The tumor has changed, the location has changed, everything has changed. And you are going to plan and do the operation exactly like what you have done 30 days ago, that is to perfection. That is really unbelievable. So I told them, I said, that is not acceptable. We'll do it in real time. So that's why, that is the very naive professor that would say. And he looked at me, good, how, right? And that's the start of the story. And so what happened is that we designed the plan so that it's a really simple problem if you think about. It's a prostate, or you can think about the breast because it is pretty much equal in terms of the type of treatment. It's a prostate the size of a walnut, and you have to put inside about 300 seeds, okay, very tiny seeds, right? Just tiny little seeds, so that it has enough radiation to kill all the tumor cells, but yet it will not kill anything else. Well, of course, it's not possible. But how do you solve this problem? For those of you in computer science and in combinatorics, you know that this is a combinatorial problem. This is one of the hardest problems, and you are going to solve it in real time. He gave me 5 minutes, though. He said 5 minutes is acceptable. So, but of course, it didn't work because, you know, the moment the doctor prepared the patient, they turn around, are you done? You're like, okay, no, I'm not done. So this is the idea. So then he asked me, what do you need in order for you to start? I said, I need 100 patients. And they told me, no. You don't get 100 patients. That would be millions of dollars. I said, okay, how many patients? 20, would that work? I said, yes. Now that is really, I think I was very fortunate there. Getting data from a doctor is almost impossible even now. But I was able to really get the patient data within 3 months. So I was able to get that, and we built a model. And we were like working quite hard. I think half a year later, I got some really nice solution. I took it to Marco. Of course, our nice solution means what? Beautiful numbers, which we don't know what the meaning is. And so he took it in and processed it and make it into the image, beautiful images, which I'm really so impressed. And then they were screaming. I said, wow, is it good or bad? So they said, this is the most beautiful plan that they would only imagine in a textbook, in theory. And of course, in the next thing, how did you get it? I say, come out from the computer, right? Remember, I don't do it by hand because it is not possible to do it by hand. Then the next thing they say, how fast can you do it? Because they want to implement it. So that is the idea of being able to test the idea. And so by 1998, they started the clinical trial. So that's the prostate cancer clinical trial. And they started at the beginning, it's just one site and then multiple sites. And I will show you just one slide on the result. So this is really quite amazing. It is one doctor that is willing to take the concept of a very crazy professor, right? I mean, because I don't know anything about cancer. And I know, like Tori was saying, people test me. And our own colleague would ask, like if everybody has a prostate. I said, I don't think so. I mean, but you know, it is interesting because for a guy to ask me, right? Because I don't know. I mean, I say I don't think so. But on the other hand, it is regardless. Is that this is about a tumor? It doesn't matter where it is. Is that we just try to really make it work for the patient. So this is really very interesting. So the clinical trials went on for 6 years, and in 2006, it got the FDA approval, it licensed, and it becomes a standard in the United States and in the entire world. So this is the interesting part. Is that if things work well here in the United States, it does really propagate to outside and it's adopted. So that's really quite important. So this is about the image gutter thing. This is new. This is now it's in clinical trials in 2011. This is on cervical cancer. And so as you can see that like there are many different type of projects that we do, but I think I cannot complain in terms of like the time because I know the FDA always reminded me it takes 17 years to get things into standard. So it only took us really 7 years. So I can't really say anything about that. Like if I complain, then I know somebody will get really quite upset about it. So now that's a chronic disease model, and chronic disease is quite complicated because it is not about just the treatment. It is really about the upkeep of individuals. What type of food you eat, how do you take care of yourself between the treatment, how do you manage your medication. And I think that's all like kind of a complete schema of what we do there. And that's also the drug delivery design. So this one, we work with the defense on helping, really trying to change the pipeline of the drug delivery so that we can actually identify the drug faster. That's one of the reasons why the pharmaceutical is so expensive in terms of the type of drugs that we get, is because the failure rate is so high. And the longer time they test it before they know they fail is billions of dollars being spent. And sometimes it is really difficult in terms of for them to be able to recover the funding, and so they will put everything that gets out and work, they're going to charge you for a lot of money. So because they have to make sure that they actually get the profit. So we want to make sure that that's how, how effective we can get it and fast in terms of being successful. So these are some of the parameters. For those of you that are interested, I just give you one example. This is the cancer, putting the seeds inside, and I'm using the cervical cancer as a model. So basically, this is the mathematical model, really looking at the tumor control, looking at different type of patient characteristics. Now, if you really love mathematics, this is what you're facing. So this is like, mixed integer programming. Of course, like Jay can tell you, it is hard. It is hard. I don't have to show you that it's hard. It is very hard. So when we first did the prostate cancer, I told you the doctor gave me 5 minutes, right? What happened when we tested in the hospital? And so they set up everything, and they put the stuff in, and then they turn around and get something, and then they look at me, are you done yet? I said, this is only 30 seconds. So you see, you have 5 minutes for me. And as it turns out, no, they really don't have 5 minutes. What they really have is just seconds, because the patients are lying right there, right? I mean, so you can't just have the patient just sit there and not doing anything. So the real time is real. And I need you to understand, okay? When I say real time, it really, when you blink the eyes, the solution has to be there. Why is that important? Because when they actually start doing the operation, they will see something happen, and they have to be able to re-optimize, right? So that's really very important. They need those capability. So, and then, of course, we do some of the theoretical results. So these slides, maybe for those of you that are still junior faculty, I think one of the things that is really difficult is the following. Is the faculty is always worried about getting tenure. And they always worry, will I be able to get tenure if I'm going to do applications? Because maybe there's no advances in my field. The answer is that there is, and there must be advances in your field in order to be able to solve these problems, because we don't have an answer for these problems, right? That's the part that I think is really the beauty, is that medicine is so advanced in terms of being able to generate all sort of data. That's the advance. But what they don't have is behind the brain, the one that gives them the decision support. And that is really what they need. And for those of you that do real-time sensors and stuff, you notice you can collect a lot of data. But the data would not be meaningful if you cannot really figure out what is the knowledge, learn from those data, and how do you incorporate to make decision in the next step, right? So that's very important. So in general, the objectives are very complex. There is not a single doctor can tell us what the objective is. In fact, they will tell you everything, and they draw many graphs, and very interesting, they actually draw many graphs, and sometimes the first thing I ask them, not so much about what the meaning is, I say, what are the axes? I said, I need to know what the axes are before I can figure out what this curve is, right? Because they say, Eva, you can tell this is what we want. I say, okay, this is what you want, and fine, but I need to know exactly what does that mean. So it is quite important, because once you get their attention, the next thing you have to do is you have to be fast, because they have absolutely no patience. So now it's like we have no patience, right? They can have, so it is a two-way street, is that my students love to complain about not getting data. This is the lessons learned from them. So they have to present the work, and they said, we spent 4 months waiting for the data, and we have exactly 2 weeks to analyze it and present it to the medical director. So they complain about that. And the medical director is right there. You know what they say? Get used to it. This is how it works. And unfortunately, that is really how it works, right? But the students think, well, we were not given enough time. So I think time is never sufficient, because if you say you want to be able to help the doctors, really tell them and show them you can help. And that's very important. Or else, if they wait for 2 years and not seeing result, that is not going to sustain the collaboration. I think there's a lot of challenges here. We have to be patient, but on both sides, like really, we have to understand the limitations. I think I was really lucky is that Marco was willing to test the concept and use it right away and see what's going on. And it is not always the case. So now the outcome is clear, right? Outcome is really clear, is that you are able to raise the quality of the treatment, and that really benefits the patients directly. So this is the part that is really important. And I was very lucky is that one Saturday, I was in the hospital with Marco. And so there's Marco playing with all these little things that looks like little toys. I said, Marco, what are you doing? We have to do the prostate cancer. He said, no, today is tongue cancer. I said, all right, tongue cancer. And so he said that he has to treat this cancer patient, 7 years old, that has tongue cancer, that is typical for a smoker, that chew tobacco. There exists not a single equipment that is in their place that actually could feed the mouth of this little patient. So then the team of doctors and everyone, basically 24 of them, were all there doing something, okay? And they said, I don't care how much time it takes. They said, we must treat the patient and we must be ready on Monday. So that's why they were there on the weekend, because operations usually is on Monday. So I think this is really the beauty, right? And I'm part of it, even though I don't know anything about tongue cancer. So okay, good. So we are going to optimize. I said, good, then you guys are doing the design, and I'm going to optimize how we are going to be able to put the little device inside. So that is really quite something that I learned, is that it is not about money. It is everything about what you can do and do the best. And I think that I learned really well. Now, as I mentioned, the cause is never an objective function. So this is the 10 years result of the prostate cancer. The red line corresponds to the before. So that is the urinary tract infection before the type of changes that we have made, and the blue one is the new one. So basically, you can see that patients sustain about 8 years of urinary infection in the original case, and then and the media is about 36 months. And for our case, the media is 9 months, and it's basically go away after 2 years. So I was also fortunate is that patients were calling me from everywhere. And that was the guy from England. He called me. He said, Dr. Lee, I want to use your treatment. And where is it available in Great Britain? I said, well, unfortunately, it is still in the United States. And so I said, if you want to come to get the treatment, there's only one place you can come, because it's still on clinical trial. So he came. He got the treatment in 2000. Nothing, too exciting. Like I didn't meet him. He just told me that's what he has done. 2005, he called me. And he said, you remember me as a patient? I said, absolutely not. I don't remember. But as it turns out, he said his colleague also had prostate cancer patient exactly the same time as he did. And he said he cannot not call me. He must call me because he had no side effect whatsoever. And his colleague still has side effect. And I told him, yes, 5 years, maybe a couple more years, and that will. But this is really an interesting part, is that it is really quite, how do you say it? It's very personal, right? People actually will come to you. And I have patients coming with all these things, like with stacks of notes that they have taken from all the doctors, what is the best treatment. I said, okay, I said, wait a minute. First of all, I can't read all your things, but I can tell you what I know. And so it is quite a personal journey, like in terms of people are willing to share with you what's happening and ask you for advice. And I'm not a doctor, so they don't have to get my treatment, clearly, because I don't make any money out of that. So I think this is really quite interesting. And now that's the tumor control probability. So you just look at the tumor control probability. The standard is the red one, and the blue one is the clinical trial one. This is for cervical cancer. So again, this is really beautiful results. And we were also quite lucky. We started in 2010, the fall of 2010. In the summer of 2011, they started the clinical trial at Rush University. So you see the effect is quite nice, is that the doctors are willing to really look at what's happening, and they don't give up their clinical plan. They still do the clinical plan. They compare to what we have, and then they make a decision which one to go ahead. So the third one is the operations advance. And this is more like not so much on the patient side, but it's more on the logistics side of how do you handle different type of operations during emergency or in the hospital workflow. So public health emergency preparedness, that happened in 2000 and I think 2002, the December of 2002. So I was contacted by CDC. And what they would like is to be able to design treatment plan or dispensing sites in such a way that when there's a pandemic, all the individuals could go there and get treatment. So you have to design where to put those sites and that how do you actually put all the people into different places. So interesting is that that is all that they want at that time. Is that they say, Eva, I have 25 people. How do I accommodate, how do I put them inside the clinic so that I get the best operations? That is their objective. Of course, I told them, you want more than that. So we actually, Christmas Eve, which is very nice because nobody was at school. So I was with the CDC colleague. Now, first of all, they have already built the simulation, and they have already tested the optimization, and they realize it is really hard problem. But you know, you are the professor, right? You say, okay, I want to test how bad, like how hard the problem is. If it is hard, yes, we're going to do it. If it is not hard, I give you the solution and we're done with it. So Christmas Eve, and so we used hundreds of computers and tested it. As it turns out, it's really, really hard. Because you don't just do the operations, like simulate the operations, you also optimize the staffing. And it is really quite hard. And so I was convinced, and I said, okay, we're going to do it. And of course, it is a lot of fun. And then they say, that's good. This is Christmas. This is 2012. But of course, they forget it is Christmas, right? That means I have only 5 days of 2000. I know, or like 7 days of 2012. And they said, we need to use it in the summer of 2003. So I said, okay, fine, yeah. Whatever that you want, we will see what we can do. So what happened is that after the test, so we basically built a simulator from scratch. We designed it so that not only it just optimizes staffing, you can also design your clinic just with mouse click. You can design your clinic, you can look at the infectious disease across the whole site, and you can look at the workers, interpreters, and everything, including, like, in addition to the healthcare workers. So that's what I'm saying. They will never be able to tell you this is what they want. Because all that they want is one thing, right? Because that is what's all on their mind. But I think the idea, so when I actually presented them the system in 2003 in the summer, it's very interesting. This is exactly what we want. I said, good. But there's the catch there. It's that, except that now we have to give it out to the public health people. And so I was it was a guinea pig in a sense, and that's a little biased because the CDC colleague that came to us are Ph.D. in engineering. So she used the system. It's easy to use, right? because she's one of us, so it's no difference. And then she gave it to her colleague and the public health people. They said, I have no idea what to do. No idea. I said, good. Now we know exactly what we have to do, right? We have to design the system so that it's really easy to do. So what happened is that we basically redesigned the whole system and make it so that it is really for public health people. Because a lot of times we work with companies, and companies that we work with have really sophisticated IT people. But public health people are really good with what they do, but they're not trained as an engineer. So 2004, the New Hampshire public health director came to Atlanta, just passed by Atlanta airport, and he called me. He said, Dr. Lee, can I see you at the airport? I said, okay. I don't know what he wanted, but then I said, okay. And then I went with my system because he specifically asked for that. And so at the airport, we spent an hour on my system. And this is a guy that has never used a single decision support system at all. Okay? And this is a very complicated system, even after we make it user-friendly. And very interesting, that is Michael. And so he shook hands and said, I gave him the system, I said it's free. So I actually was able to negotiate so that I can give it out for free to the public health people. I said, okay, you can use it, and if you have any questions, send me emails. And then I thought, then CDC asked me, how did it go? I said, I'm not so sure if he would ever use it and if he would ever call me or anything, but I tried. So then Monday, what happened on Monday? This is what is unbelievable. On Monday, he sent me a model that he built on my system. This is by far the most complicated and most beautiful model that we still keep it on the system now. So this guy told me he doesn't know how to do it. So he said, I really don't know what to do, and I'm just trying little things. But in addition to all these clinical plan of workflow, you know what he added? Line controllers, helpers, and he adds everything that is supposed to be there. And that's what we want them to know. So Michael turned out to be the perfect ambassador because he literally does not know how to turn on the system. So, but yet he can, because we designed it so that it is really easy for you to do and really build up his confidence. Now, what happened is that afterwards, and we have distributed that to, so what is going on is that the system itself is designed so that it is, at the beginning, is really for biodefense, it's for biological defense, and it is used, it can be used for all hazards. So the hurricanes, for police department, they have been using it, the military, and it was used in also Haiti for the operations, as well as in Japan. But of course, there are many different components to it. So what happened is that in the back end, it's very complicated mathematics. This is really just for the faculty. Like I say, for those of you that really love mathematics and cannot live without it. And so that's the facility location. There's the multi-source allocation optimization within simulation. That's disease propagation and how the disease spread across the whole, like when people come in, how do you control the disease and everything. So this is really beautiful because from our point of view, is that I don't mind to develop a system where if all the technology is available, but I also like to be able to say, look, this is really something that is challenging for us, and I think it's really nice. And plus everything else. It is not just the mathematics and computer science, there's the information technology, the GIS, visualization, and all the real-time computing. When I talk about real-time, again, a blink on your eye, and that's it. That's how fast they are going to really look at it and want the solution. So that's the emergency response system here. This is one of the work that we did, like this is New York City. It shows you how many workers. It's a little bit hard for you to see interpreters and how many capability or what are the number of resources that we need. And this is the communication system. I'm showing you Georgia, a network of 141 hospitals. When there's a disaster, you will know how they connect with each other and how you share the data so that you will prepare the type of hospital beds that is needed. So it's all connected. So I think I was really lucky. I got those data. They're all paper. So it really kills us because you cannot do anything on the computer with paper. So you have to really design your own database to absorb all those data. But once you have that, then you can do everything beautiful. Now, the rest is history, right? So we were able to disseminate it in 2005, and then it is being used, and of course there are many different components. So we have now about 8,500 public health sites used. It's used in many disasters, emergency response, and it's also used internationally. There were lots of requests, but this is really a proprietary product for the United States. So I was in Japan for the disaster. Now, this is one of the projects I never talked much about because radiological emergency response is really for protection, not so much about defense but it is really like all for protection of the population. So I was really shocked after the earthquake, what happened. And so for the longest time, I complained there were no data. And then all of a sudden, I was really shocked at how much data we have. And so I was on the ground in Japan during the disasters. And to give you an idea of why such type of system is important, after the first wave of earthquake, the tower that actually were the emergency response managers' tower, there were 30 managers there, 19 of them perished. So if you think you really have the manpower and the talent, think twice, because you may not have any on the day of the disaster. Not so much that they don't come, it's just that they probably were not there anymore for you to really use. So I think it is really quite real, and in terms of like, not only you're protecting the citizens, you are also protecting the emergency response workers and making sure they know exactly where to go. So I think this is a pretty last couple slides that I have, because I see that I don't have a whole lot of time. So this is the systems approach that relates to the talk that I did in the afternoon. Basically, this is about how do you look at the system? So this is the mental health. One of the things that is really challenging for doctors is where does the patient go? And you would think they know exactly where the patient go within the hospital. It is really hard to keep track of them, especially the mental illness patient, because they go on many different levels. How do you make sure you can map out? So we map out the entire system for the VA, and in terms of like where individuals actually go through the system, which is unbelievable, complex. And I think this is the fun part of it, being able to tell them exactly what do they need the resource and what type of patients demand that they need. So I think one of the things that is really important is the timeliness of care, the quality of care, and how do you coordinate, how do you make sure it's cost effective. And I think cost is going to be important, even though it is never going to be in our equation, but it is a side effect. And to give you an idea, the prostate cancer project saved $500 million in healthcare just on the pre-operation procedures, not anything about side effect control. Because you're doing it in real time, the patients do not have to come in a month in advance, do all these complex things. So you save just $500 million for reducing that part. And then, of course, you save billions of dollars on side effect management that you reduce that way. So this is important. But I like to see the more important part is the quality of care. So if the patients are healthy, then that's really worthwhile. And you're not going to pay more money for that because you know you will get that in terms of the SSI effect. So that's the technology. So I mentioned about human cognitive and being able to, healthcare remains very human-centric. I don't know if you feel better if you get operations with a robot versus a human. So how many of you would trust the robot better than a human? Which robot? Yeah, of course, it has to be a good one. But you know who designed the robots at the end? It's the human, right? So healthcare is very human-centric. After all, the patient is a human. No doubt about that, right? We can't replace the patient. And so the difficulty in healthcare is intrinsic because the patient is being cared for by many different types of people in many different levels. So the key to make sure it works is that you have to get everybody work towards a common goal. And that is not easy. So this is one example, the emergency response, emergency department. What I'm showing you is the ED transformation at Grady. So Grady, and I already have talked about that. So one of the things that Grady have problem is that it is the 5th largest public hospitals in the country. It serves 125,000 patients just in the emergency department per year. So if you think about Grady, they would always say they operate at 150%. What they really mean is they have patients lying on the floor and they need care. Okay, so this is really what it means. But will Grady get more money? Absolutely not. Because Grady's patient is so different than any other hospitals. It has only 8% patients that have private insurance. And basically, a huge percentage of them are Medicaid, Medicare. And at the moment, because Georgia did not accept the extra Medicaid, Medicare from the Obamacare, they are really in big trouble in terms of just finance, right? So if you think about this one, from the patient point of view, how would you feel? Do you like to stay in the ED longer or shorter? That's a no-brainer, right? I mean, I think this is the nice part is that the objective for the patient is clear. It's absolutely clear. And I love that because I think that is really the objective that we have is how do you optimize the treatment so that the patients spend the least amount of time in the hospital and getting the best care and using the least amount of resource. So nobody is willing. So remember the first thing what I talk about, right? Quality. Nobody is willing to say, look, you come in and push you out. That is, okay, that would be very fast, but there's no quality. So you don't want that. You want quality, but you want efficiency. And that's really the key part that I would like to mention. So, and this is just for you to see how it works, all the methods. And I won't go through that in detail because I have the talk about that this afternoon. So this is the last slide. And the challenges is multidisciplinary. I think all of you understand. So there's not a single person in the room that can do everything. It's absolutely not possible. So you need to work with each other. You need to be able to communicate, whether you like to talk to someone or not. Right? But on the other hand, I think if you love the problem and you want to be able to help, you will talk to them. So I think this is really, that's your motivation. Nobody's going to be able to force you to do that. Data is evolving. That means today you can solve the problem. It doesn't really mean that it's valid for tomorrow. Unfortunately, this is what's going to happen. So my colleagues in the clinical side love to tell me that you guys are so slow. So, I mean, one of the things that's really interesting is that I think Tori and Jay could say, so you know, the OR people, they do projects, right? They do projects, and all of a sudden, everybody's doing the same project, right? At conferences, you hear. But it really makes no impact whatsoever to the clinical side, because we are like, okay, 6 months too far, you know, behind. And then they have new technology, they have new imaging, and now that is their problem. And then my medical colleague, you guys are still there, okay? So I tell them to move faster. All right, so that is truly the challenge. It does not matter when you get the data, but you will have to run with them. And the best is to be able to run with them together, right? But you will never be able to run with them together because they will always generate data before you know. So that means you have to run faster then, so that you will at the end catch up with them. I think that is really true. So I think I learned a lot. Is that I remember Paul as one of my best students, and I remember he took this project, and okay, I told him, Paul, you want clinical significance, you want the doctors to really care about your result. I need it next week, or else forget about it. Okay, Paul came back with the solution 8 months later. And it's funny. So I told him it's too late. And he said, oh, but they didn't have the answer. I said, they have the answer. Exactly the week after I told you, I gave them the answer. If they're going to wait for you, that would be like never happen. Right? So and he learned it in a hard way, because I sent him to the hospital, and he realized it right away because the doctors, he noticed how they operate, right? So that's how they learned. And I think the time is really critical. We have lots of capability. Technological advances is really important. Today, your algorithm works. Tomorrow, there's new computer, new algorithms. Can you adopt those immediately so that you can advance that? Are you able to do that? So how do you measure outcome? I think this is still extraordinarily difficult, and I think the doctor is going to tell you it's very hard to measure outcome. You have to document changes. You have to be able to figure out what is correct and what is not, and how do you actually measure the outcome of the patient in order to see it actually is helping. So I think it is also important to make sure that effort is sustaining. So if you get good results, how do you improve that so that the next step continue to improve? Because if you don't improve, you will fall behind. And I think that's important. So I want to thank all my funding agencies. And it's true, nothing is going to stop me from doing the research. And I think when we first started the cancer research, we didn't even think about getting fundings, because I think I was a little bit naive to think about is that all that I have time to care about is the research, which is really true. So when we actually get the Edelman Award, it was really interesting because everybody asked Marco, how much money does it take to do the project, or what funding? And Marco was really quite honest. He said, we didn't know we need money, so we didn't ask for any money. And because we do it for free, right? This is true. And I think it is really quite important for us to realize that it is hard if you start a project to ask for money, because I think your objective is not money, right? And it is the same for the doctors. Their objective is not money. All that they think about in the whole head that they're thinking about is, how do I do better with the patients, and how can I do faster so that I can treat more patients that need our help? That is really on their mind. And I truly believe that they have no time to think about anything else, and they will not talk to you if all that you're going to talk to them about is money. So I think that was a good, it was good for me, because I wasn't savvy enough to think about anything else except the problem. And so I was so amazed by the mathematical complexity of it, and I think this is really important. Of course, we got lots of fundings now in terms of different projects, but I think I would say of all the projects I do, at least 50% of them are all voluntary projects. We have projects in Tanzania, we have projects in many other parts of the world, and they are really quite fun to do. So hopefully, I'm sure many of you are doing quite exciting projects, and so hopefully this gives you a little idea of what I do. Thank you.
Thank you very much for a very nice and interesting talk.
Thank you.
Energizing. Any question?
Dr. Lee, talking about personalized evidence-based treatment looks complex, but in real-world situation, the patient may have more than one disease. For example, diabetes, heart disease, acid reflux, and cancer, prostate cancer, breast cancer. So how do you handle when there is so much synergistic effect of all these medications?
That is a perfect question, and that's actually precisely what we are doing. Is that we are doing polypharmacy. So what it does is that looking at different types of medications that the individuals are taking and put it all into the complex network of drug-drug interaction and the effect of the drug. And also different conditions, because there's really a lot of patients have multiple conditions. So they're not one condition. So in that little chart that I gave you, that is for chronic disease management. It is for multiple disease, indeed. And I think the complexity is really difficult to acknowledge in terms of like, first of all, you have to be able to map out all the drugs that they're taking. Then you have to understand all the interactions of the drugs. And you optimize the outcome of the effect and then minimizing the risk factors, right? Because understanding that there is not a single chance that there's no side effect. So that's really important. But the idea is to minimize the type of drugs that people are taking, because I think and you see in the news they talk about most patients with chronic disease, they're being prescribed 5 or 6 different types of drugs. And so on any given day, 5 drugs, if they take it 4 times a day, you can multiply, right? It's a lot of drugs. For every single pill that you are not taking, somebody else is taking it, right? Because on average, that's what they are saying, about 30 drugs per day. So it is really quite complex. And patients are not good with compliance. So the idea is really to be able to come up with a plan with the minimum amount of drugs, right? That's the first one. And second is, how do you design it so that the patients also don't have to take it so many times? That's also very important, because it doesn't do you good if I tell you you have to take it 10 times a day, or 3 times a day this and 3 times a day. And then you have to be responsible for remembering when you take it, right? I don't know how many, maybe some of you are really good in doing that, but I mean, I personally, I never take any drugs or not over the counter. If I have to take one pill, I mean, I think my husband has to like keep reminding me, and he has to put the pill in front of me, and then at the end of the day, he saw it still sitting there. So it is not easy. So I think it's like, unless there's a little robot, I think that will work. The little robot come and say, now you must take it, or else like the robot is going to do something to you, right? I think that may work, but I think this is a challenge, and this is actually what we have been doing for chronic disease management. This is also something with trying to change the behavior of individuals. Because chronic disease, most of it, like 50% of it, is really contributed by bad behavior. So there's a big New York Times article, I don't know how many of you have seen it this weekend, just yesterday, that talks about, like this guy said that now he's 80 years old, and he's ready to start smoking again. So, so there's the healthcare provider that is written about when is it like that you have to live your life in a responsible way and healthy way versus you should enjoy the pleasure in life, right? So it is an interesting contrast. So are people living too long that, I mean, one of the crazy things people say, are people living so long that they don't die and everybody's healthy? I say, you don't have to worry about that. I don't think we are going to have a nation in which people are so healthy that they will not die. Okay, so that hypothesis is not going to be provable. But on the other hand, I think it's like whether the lifestyle is good or not for you is very personal. But I think the chronic disease one, really 50% is related, unfortunately, to our lifestyle. But that is the catch. So this guy started smoking. Who is going to die? He is not going to die. The largest amount of people that died of lung cancer are the secondary, like smoker or whatever that you call them. A lot of women, a lot of young women that are dying, and they are not smokers, right? So now, do we feel really good for our bad habits to influence someone else's life? Then that is ethics, right? Now, engineers are not good in ethics. But on the other hand, that is personal responsibility. So I think it's hopefully I answer your questions, but it is complex. But I think we're not trying to change people's behavior because it is difficult. I think engineers, you can design things to change the behavior, But on the other hand, at the end of the day, it is the individual that is going to make the choice. But if your choice is going to influence someone else's life, then I think you will be a little bit more responsible. I don't know if that guy would. He's a famous musician or something. Yeah, he decided to start smoking just this year because he just turned 80. So it is very interesting, I think.
Thank you very much. Since we're out of over time, please come and ask.
Thank you.
Enjoyed your talk very much.